Manisha, how does tumor size influence your treatment decision in radioactive iodine differentiated thyroid cancer? And moreover, what percentage increase are you looking for to start or change systemic therapy?
So really there is no formula. As I tell the patients that don't ask me how big my tumor has to be before I can start the therapy. It's really multiple factors that play a role, such as pace of progression and location and so forth. So in general, we wouldn't treat patients who have, for example, 5 millimeter multiple nodules and they're asymptomatic and their disease is stable. But size alone doesn't shy us away. So if they have progression within 3 months, that no longer is slow growing. And even if their tumor size, the biggest is 1.4, but they have multiple tumors that have grown within previous few months, then that would be a candidate for starting systemic therapy.
Yeah, so size itself doesn't matter so much, and we certainly get that question a lot. Nefa, Manisha mentioned tumor progression. How does that factor into your decision?
Yeah, so when the patients are deemed radioactive iodine refractory, we do something similar to what Marcia described, which is, do the active surveillance every 3 months, CT scans to see what is their actual true rate of progression. Because very often these patients have just had ultrasounds and radioactive iodine scans prior and didn't necessarily have cross-sectional imaging, and then they come to you. And so trying to figure out what is the pace of progression. Are these truly new, or did they have the coincidental chest X-ray at the car wreck? And so if they're progressing over a 3 to 6 month pace, that's a much poorer prognosis rather than somebody who's progressing maybe over a 2-year pace. And so taking all those things into account and trying to get the patients to understand that is very important, because a lot of times these patients have had their disease for 15, 20 years and it hasn't grown, and everybody's told them this is the best cancer you can ever have, and now you're having this discussion about systemic therapy. So taking all that into account, and location of tumor in addition to just size. But from percent tumor progression, for the clinical trials, we're using the RECIST criteria that's typically used in other malignancies. But on the day-to-day clinical use, that's a little bit harder to do for exact RECIST. So we're not using exact RECIST criteria in day-to-day clinical activities, but it's the gestalt of what's been happening over what period of time and how it's growing.
Can I add something to that?
Please.
Go ahead. Gary, you go first.
So I think this is a really important point of discussion, because many of these patients are not in this treatment area at the time that they're diagnosed and they're RAI refractory. They're seeing their endocrinologist that they've seen for years, or their surgeon that they've seen for years. They've been monitored. And the real question is, it's different for us because we're working in an interdisciplinary program. So patient comes in and sees me and sees Knife in the afternoon. They're seeing the same radiographic studies. But I was across the street and I was seeing the patient myself, and I'm monitoring these 3 to 5 millimeter multifocal pulmonary metastatic deposits, and I've been watching them for 3 or 5 years. And Marcia mentioned earlier about get me involved earlier. How much earlier? And if just some of these 3 to 5 millimeter deposits, they're noticing a couple more on their CT scan of the chest, do we want to get them involved now? How active do we want to be in this process?
I can answer that, actually. I'd say yes now, because I'm totally fine seeing a patient once a year. I don't mind not being the main person, but it's so important for me to judge where they're going to be and also when I'm going to start therapy, that we're actually seeing them. As I said, my start point is once they're deemed radioactive iodine refractory, I want at least to meet them. And it also, I found, helps the patient, because most of us, as you pointed out, are in these multiple disciplinary settings, but many of my patients come from the community. And what happens is they're told they're radioactive iodine refractory, and they feel a little bit like a ticking time bomb, and there's actually a sense of reassurance the oncologist can give, saying, listen, we're going to watch you, but not to worry, because if it grows, we have something to offer. And I think that that's something we can offer on the oncology side, because we do have these drugs. And so I really do feel in the community setting, especially when you're not actively engaged with an oncologist from the beginning. And there's another point of Naifa's that I'd like to also build on, which has to do with the pace of the disease. because while we have these wonderful data now about how active these agents can be, phase 2, many phase 2s actually, and the decision trial, which was positive, and now the lenvatinib trial, there are a group of patients that actually are rapidly progressing. And more so than whether their genotype is BRAF or not BRAF, and more than the fact that they are, this histology or that histology, the poorly differentiateds tend to rapidly progress. And we've seen in the decision trial is that the 10% or so that are clearly poorly differentiated, using strict criteria for that, and they've been recently published, so we really should stick to that definition. Many of them do a little less well than everybody else. So, we have these medians, say, of a year of progression-free survival, or maybe 15 months or longer with the lenvatinib. But that group of patients are the ones that may start and still progress within 6 to 8 months. And so I think also going forward, there's going to be a need for clinical trials to look at those. And those patients actually eventually would be good for clinical trials for combination therapies and perhaps a more aggressive approach. And I just put it out there. We don't have an answer, but I do think the poorly differentiated, these rapid progressors, we still treat them the same way. We still give them the opportunity to get sorafenib, but I think that you can probably expect that they're more likely to progress at 6 to 8 months, and I'm always watching them much closer.
Sure.
That's a good point. The other thing I'd like to mention that there's emerging data now based on our clinical studies that symptoms and size of tumor burden really plays a role. So patients who have tumor burdens over 2 centimeters are probably more likely to respond to treatment versus those not. And in terms of improving progression-free survival, the same thing, people who are symptomatic versus those who are not. And I think that's the big thing we need to weigh in and out is the quality of life. People will come in and see me, it's like, I hear you, the side effects, I'm just not quite there yet. And so that, watchful waiting and surveillance is really important, but to really find the right time, I think, is a discussion one we need to have between us and the patients.
Mm-hmm. Certainly. Frank, what about, before we leave this topic, what about tumor location? Does that play a role?
Yeah, actually, in patients who come in with primarily pulmonary disease, they say, you got a bad problem, but you're kind of lucky because you're more likely to respond, to treatment versus those that have, a brain met, even with treatment or have advanced bone disease. So that does play a role in the treatment, in terms of response, but also in terms of treatment for symptoms and, management with radiation or other local modalities.